So good morning, everyone. Welcome to the Shared Learning Forum. And today I'm going to let our guests introduce themselves. I just want to let you know that the Shared Learning Forum is a mighty group of three, which is Tammy and Jason and myself, who look for topics, or you guys give us feedback, which is even better, on topics that you want to learn more about, or if you have great contacts that you think would be a great topic. We do it it's a free session every month as a resource, and then we record it and we upload it to Connectability. So Jason makes sure he does some nice edits, and he puts it up in Connectability. And if you go on the page, you'll see all the past presentations we've done over the years, which I have to say the viewings on those are pretty amazing because they continue to be a really important resource for perhaps staff that are new to the sector or new to the job. And so the great resources there if you want to take a look. What else can I tell you? So this is typically our audience is the developmental services sector, health, and I know I shared the link with some social workers with the Toronto School Board as well, because this is a topic that is very, very love to hear about, get more details, and we have two experts to talk about that today. So I'm going to pass it over to them. And if you have questions, I think we'll get through it. I'll let them sort of decide how they want to run the show. But if you have any more questions or any feedback around other topics, please email Jason, Tammy, or myself. We'd love to hear if you have any connections, and we'll set you up. So I'll pass it over to Angie and Megan.
Thank you so much for inviting us, Deanna and Tammy and Jason. Thank you. We really appreciate it. My name is Angie. I used to be a healthcare facilitator with the Community Networks of Specialized Care, and I see the new healthcare facilitator is here, Alicia Walji. So welcome, Alicia. Thank you for joining. And now I'm transitioning over into a new role with the Plus 45 clinic at Surrey Place. My background is I'm a clinical nurse specialist, and I am not so much the expert as Megan, so I'm going to hand it over to Megan.
I don't know about that, Angie. I think we both have imposter syndrome, but I am an occupational therapist, and my job title at Surrey Place is Transitional Services Facilitator. So most of my career has focused on transition-aged youth and sort of what factors go into community participation versus more institutional settings. So I used to work at Sick Kids in the Good to Go program, and I'm really passionate about any sort of factors that help people live full lives in the community, doing the things that they love. And so that includes everything from getting good healthcare to trying to set up great activities in the community and getting funding and support and all of those good things. So I am going to be trying to share the PowerPoint presentation and keep an eye on the chat at the same time. So if there's anything where I am missing a question or something is coming up and I'm not cluing in, if you guys can unmute yourselves and then let me know, that would be some important housekeeping. But otherwise, I'm going to be trying to share my screen here and just get
Megan,
started.
Jason's going to monitor your chat, okay? So don't worry about that.
Amazing.
The topic today is transition to adult healthcare, and it's from the lens of my nursing lens and from Megan's lens as a transitional facilitator. So yeah, just making sure we say that we don't have any anything to disclose or no conflict of interest to declare. So today, the learning outcomes are, we're going to talk about higher prevalence issues for transitioned age youth, and we might refer to that as TAY or TAY, with people who are living with intellectual and developmental disabilities. We're going to talk about approaches and opportunities for promoting decision-making capabilities in supporting persons with IDD, and in the context of transitioning from pediatric to adult healthcare. We're going to consider examples of tools for optimizing transition support. There are three main tools that we're going to highlight. The Share Transition Plan tool, which Megan was a key part of working on that tool. The My Hospital form, there's also a transfer tool that we'll talk about. And these are all coming from the DD Primary Care Program that's on the Surrey Place website. There's also new mental health tools that we're going to share. So we'll start with this Mentimeter poll. If you could use the QR code or just go to menti.com and use the number code there. But we wanted, and you can also put it in the chat. We wanted some words that come to your mind when thinking about transition concerns for youth with IDD.
So I'm just going to pause the share and then move over to the Mentimeter.
Yeah. So when you came today to this topic, any words that come to mind that you're hoping to hear about or that you're thinking about or concerned about? Resources, that's great. Structure, that's great. We hear about the hitting a cliff, and therefore support is perfect coming there, right next to hitting a cliff. Ooh.
Great.
New independence. Wow, I love that.
that.
Service gaps, definitely. Housing challenges. Scary. Yeah, it is very scary. Trauma. Yep. From my lens, it's accumulation of medical trauma.
Mhm.
Caregiver support, not ready yet. Wow. Unprepared. Limited options, lack of resources.
There's a few coming in
Yeah.
on the chat as well. So isolation, consent, uncertainty.
Confusing
Yeah.
for both kids and workers, future placement. Yeah. Yeah.
So seeing this, yeah, I mean, transition supports have been in healthcare being proposed and lots of tools and resources being proposed for over a decade or more, decades now. But we're still facing these concerns and still feeling them. So yeah, I mean, these are very, very valid concerns, and it definitely resonates, I'm sure, with everyone in the room today.
Yeah.
Thank you. So hopefully, and Megan, from your perspective too, like hopefully today what we're talking about and some of the resources will at least reassure, or there'll be at least one thing that you can take away that might help. So for healthcare transition piece, I'm going to talk a little bit about hitting the cliff with healthcare. And Megan, also jump in, please, because Megan is the transition facilitator, and you also worked with in a key role with St. Mike's Hospital. So yeah, let's get into the healthcare transition piece. So this is from HCARD, Healthcare Access Research and Developmental Disability. HCARD is one of the rocks I cling to in the developmental service world. And there's a snapshot that talks about transition-aged youth. And it says, okay, in this snapshot from research, it says, what do we need to know? Young adults with developmental disabilities are more likely to have poorer overall health, have at least one psychiatric diagnosis, and have higher health service use than young adults without DD. So already, this is what we know, is that we're seeing that young adults who are transitioning have concerns that have a different higher prevalence of healthcare usage, healthcare needs, and also likely to have poorer overall health. And this is from research that is based in Ontario, statistics that that used OHIP and ODSP and a lot of data. You'll see in this video, they talk about their research. So we'll load this video.
Bear with me here.
Yeah, no, Megan, you're doing way better than I would. Thank you.
Let me know if you cannot hear the sound on this.
We might need it a bit louder. Is there a way to put that volume? Just double check the volume.
We're looking at health and service use of individuals with developmental disability who are younger. So the younger adults and how they use services through the adolescent years. This level we're looking at more specifically within H-Card is what kind of health needs do they have, both physical and mental health. So the degree of those health needs can certainly make it particularly challenging to leave a specialized health service that's been tailored to you as a youth to one that you're looking for that can give you that same level of support as an adult, because your health needs are not going to stop as you transition into the adult sector. Of the 66,000 adults with developmental disabilities or so that are in the H-Card cohort, about 24% of those are young adults, 18 to 24 years of age, that we looked at. This group of young adults with developmental disabilities is particularly prone to poorer health compared to young adults without developmental disabilities in the province. Within that, what's really particularly remarkable is the high rates of having at least one psychiatric diagnosis, which is much higher than you would expect in the general population. We also took a closer look at those with ASD and similar questions in terms of what do their health profiles look like, who are they, and how are they using services. There are certainly particular psychiatric needs that are much higher in this group of young adults with autism spectrum disorder. From a physical health perspective, those with ASD and other developmental disabilities were actually relatively similar. People with ASD were visiting emergency departments significantly less often than those with other developmental disabilities. And it makes you ask, what's going on there? The families have experienced what it's like to go to the emergency department, and it's such a problem that they're choosing other places to go, or they're seeking care, or if they're seeking care in other ways. So we know that people with developmental disabilities generally have poorer health and use the health system more in certain ways. Those things start very early in life. A hopeful impact of that I'd like to see moving forward is that we start talking about the kinds of preventative measures that we can implement at a younger age to address the severity or the occurrence of psychiatric conditions in this population. Though this project is focused in name even on healthcare, when we think about transitions for developmental disabilities around this age group, it's across many different sectors. I feel, more work in that sort of interministerial cross-sector work, including education, is definitely needed.
That's great. So I think that speaks volumes in that 4-minute video. And it also speaks to the statistics on what.
My visits because of its. Oh, sorry.
Sorry.
Sorry, it went straight to the next video.
I know. Yeah. So it speaks volumes about the resources that are still needed that are at a systems level. Things are improving. There's hope in that the ministries are working together, health and MCCSS. Hospitals are having new partnerships and networks. So there's hope. And really the message is we need to continue to try to start earlier on.
Yeah.
And that research was based on an age group that was from 14 to 24 years. Sorry, Megan.
And I also think since that time, so that I think that video was produced, or that research came out sort of 2014, 2015. And since that time too, Jonathan Weiss, that researcher that you saw, has published a lot of things around what supports mental health in young people with intellectual disabilities. And a lot of the issues around activity and opportunities to participate in the community that are important for supporting mental health and preventing some of the sort of psychiatric issues that can happen when people are very isolated, or when they have a lack of sort of meaningful activities and structure to their day, which I think all of us have gotten a firsthand lesson on in terms of experiencing the pandemic as to what that can do for mental health.
Exactly. So yes, mental health supports are challenging, and that continues to be an issue. And there's lots of research. We have references at the end that we will share from HCARD. There's the primary care crisis that's going on right now, which is a layer that is definitely something that is key for transition, because that's the primary care providers are the gatekeepers to any kinds of referrals. And it's the medical home where people go for integrated collaborative care. So primary care shortage in Ontario and the Ontario Medical Association, it's all over the media. And sorry about that. What we need to how do we then respond to that is we have to be persistent. I know that's easier said than done, but believe me, in my role in my past role as healthcare facilitator, it was persistence and kindness, and knowing that the gatekeepers and the people who are providing the care, being empathetic to what was happening with them. And trying to understand more about where complex care can be delivered in a team type setting. Because if you have a team, you can respond to complexity. So go again, and I know you've heard this message, it's looking at models like family health teams, community health centers, starting early with that relationship and showing that you have a team with you. That will help that provider with, and also considering nurse practitioner-led clinics. In the family health team model and the CHC model, there's a key role in nurse practitioners who can lead the primary care role as well. Emergency department experiences can be extremely challenging. And you heard in the video that autistic people, because now the language is also changing, that autistic people or people with ASD they have a difference in how they access emergency departments than other groups with IDD. And it's related to the environment and communication with providers. The transfer of adult healthcare to subspecialists and having that in a coordinated way, it's done really well if you've got complexity with sick kids. If you're at Sick Kids and you're with that program that Megan used to be part of, but if you weren't part of a group like that and you had maybe a pediatrician and you're transferring to multiple adult healthcare specialists across possibly various hospitals, that can be very challenging. But then again, looking at systems that have networks now, that has helped a lot. So for example, UHN, using the MyChart patient portal. The MyChart patient portal to access your loved one's records or your own records. We often, as nurses, we sometimes get the question about trying to understand reports better. And so having at least, I guess, encouraging people to try to set up that portal for access to information, that can be very helpful too. And then there's also the reasonable accommodations that starting that early on is very important. So understanding how the person has been experiencing medical trauma in the past and planning for in the adult setting, knowing what to tell the new healthcare providers in terms of what supports would be needed for reasonable accommodations is really important. So documenting that early on is important. And Megan will be talking about some of those tools.
Yeah.
Megan?
And I think people often don't feel like they can ask for certain things, or doesn't occur to them to ask for things like the first appointment of the day, or a quieter space, or to come in through the side door instead of sitting in the waiting room. You know how restaurants have those little dingers that will tell you when they're ready to see you, maybe being allowed to pace outside, those types of things. And providers are often very willing to offer a whole variety of accommodations to help that person participate. But both parties don't know whether to ask or to offer. So being able to suggest that to families, it can be really helpful too.
Yeah, so improving healthcare experiences, there are many resources to help with that. And there are tools that are on the H-Card website as well as on the DD Primary Care website. Megan will highlight in more detail some of those tools. But for the people living with IDD, About Me continues to be a really helpful tool. And there is another tool that is called the exit interview, and that's if someone has been who needs more information about what happened after the medical encounter. There's social stories, there's the getting a blood test social story, there's the blood draw toolkit that's on the Surrey Place website, and many more tools that can help, videos. And so these people might feel like they're tooled out. And it's the pamphlet intervention where we hand you a tool or a pamphlet. But honestly, these are resources that are crucial because we need to keep documenting. And it's easier than to hand something to a healthcare provider that has a very clear, structured way of presenting the information very concisely as well. It remains important. So I'd encourage, if you haven't seen these tools, go to H-Card or DD Primary Care, and we'll give you the websites as well.
Yeah, they're just good reminders for us as well to slow down and to try and have a more structured approach to these situations. And it gives us something to refer back to when you feel a little bit overwhelmed as to how to approach this.
Exactly. And the tools really are written in a way that healthcare providers also want to see, because they've been vetted by the healthcare provider lens, as well as people with lived experience. Tools for providers. So this is the healthcare transfer tool that was mentioned. Again, we saw the word structure come up when we did the Mentimeter, and this is a way to think holistically and have a structured approach. So on the DD Primary Care website, there's the healthcare transfer tool. And then there are also, we don't want to be too biased, there are other tools. So there's the complex what's that
Complex
acronym?
Care Kids Ontario.
Complex Care Kids Ontario, because I'm adult, so the
Yeah.
more pediatric side, Complex Care Kids Ontario Transition Checklist. That's another beautifully written tool.
All alphabet soup, but with the healthcare transfer tool. I highlighted these two tools in particular because the first one is really short. It's only 2 pages, but it's got 3 columns of like pediatric, adult, and what are we going to do to try and bridge this gap and who is going to address it on the second page. So the first page, as you can see there, just sort of about me, and the second page is sort of like what are the gaps in services and what are we going to do. And then the checklist, the CCKO checklist, is very detailed if you are one of those people who wants the full shebang of what needs to be done and how to plan and where the resources are, and then how are we going to find this family doctor, and all of the different resources attached to the toolkit of what to do and how to do it.
Great. Yes, and I'm happy to show you this, the My Coping tool, how I deal with stress. That's one of the new tools that is on the DD Primary Care website, Mental Health New Toolkit. And it is informed heavily by people with lived experience and lots of visuals. So again, please take a look at it and see if it will help. But this is also a way of looking at the old tool, which was the crisis management sort of approach. But this is the positive side of that approach, which is My Coping. And it is also in partnership with CAMH that this was produced, and H-Card. So sexual health, and I am very aware that I'm in the room with the guru, Deanna Jos, the leader for me in the sector. For many people in this sector, Deanna Jos is in the room, and I look to her. And so in transition, we are again highlighting that that not to gloss over the sexual health aspect of transition support, because especially when people are transitioning and going into a situation where there might even be crisis, this, Megan and I were talking about it, that this tends to sometimes be at the bottom of the topics that come up in meeting with people. We know that it's also an area that needs a lot more resources still. And the need for accessible, comprehensive sexual health education. Deanna is in the room and has this leadership presence, especially with Toronto and in Ontario and in Canada, but there's only one of Deanna. So people living with IDD, there's a lot of research. This is an example of one, Schmidt et al. 2020, that says people living with IDD may experience greater risk of sexual STIs, sexually transmitted infections, higher rates of sexual abuse, decreased sexual health knowledge. So we know this already. We'll go to the next slide. And the resources that exist, there are resources. We need to be comfortable with bringing up the topic and helping people, supporting people by using these resources. And I know many people in the room led some of these resources and know, this is basic, that we are talking about the body, and we're supporting people to model consent. So we're supporting whoever are the circle of support for the person to be aware of modeling consent. Next slide. And this is another example from Holland Bloorview, where I used to work at Holland Bloorview, and they had many wonderful resources and links and a family support role, and a beautiful resource center. So there's many things out there, and they also link to other agencies in our sector that have those resources. So places like Carrie's Place. And I saw this morning, one of the emails came up for Carrie's Place that a new group in terms of discussing sexuality is starting, sexuality and autism is starting on May 8th. So there's lots of resources there. But in terms of transition, sometimes we're not even bringing up the topic well enough. Anything to add, Megan?
No, I think
Okay.
that's a pretty good summary of the issues.
Yeah.
Yeah.
Okay. So I'll hand over to Megan.
I am having trouble getting the slides to move forward. I have the feeling it's going to skip like 6 slides forward because I keep pushing it, waiting, and then it's not
Sure.
going. So I'm just gonna try. Oh, here we go. Yeah. And then who knows when that will go. I pushed it like 4 times. So I'm going to move on to the decision-making capabilities portion. And I kind of worded it that way on purpose instead of sort of framing it in this like risk-based way of managing it around capacity and consent, because I think people with disabilities are often viewed sort of in this risk management framework. And what I wanted to do was switch it around more to the positive end of how you promote people's decision-making capabilities, and the fact that there's a lot within that that we can do to help give people more autonomy and make them feel empowered in terms of making decisions in their own lives. I am not a lawyer. We are not lawyers in this room unless there's something I don't know about happening in in terms of who's here. So what I hoped to do with this section is just give an overview of the common issues that come up for us as providers, and then an overview of how I see families resolving some of these issues within healthcare and financial contexts, and resources that we can direct families to, because we are not necessarily the people that can resolve all of those issues for families. So oftentimes, when we're working with families and an important decision comes up, like say a medical decision around having a surgery or something like that, it's framed in very black and white terms, whether or not the person is capable of making the decision at the time that the decision needs to be made or not, and who is going to ultimately take responsibility and sign the consent form, for example. And I think all of us who work in this field um, don't work in those binaries as much, and we recognize that there's this sort of gray area in the middle as to how decisions are made, and that for many of us, whether you have a disability or don't have a disability, a lot of us make our decisions very interdependently. So I have a best friend and my family, and I call them my board members for when I have to make important decisions, and I try to pull out consensus, and I value the opinions of a lot of different people in my life when I'm making important decisions. And I think for people with intellectual disabilities, if you have a disability that impacts how you process information and the speed at which you process information, I think the people around you that support you become even more important in this decision-making sort of framework. So increasingly, internationally, there's been more recognition of this sort of gray area in the middle, and a lot of provinces and territories and states in the United States are looking at supported decision-making frameworks that create legal structures that really acknowledge this middle gray area. In Ontario, we're operating in a very specific framework that does have substitute decision making and does not have this sort of middle zone the same way as like BC and the Yukon have some of these things set up. And so we're operating in a specific legal context that we have to be aware of as providers. So the issues that come up for me and that I hear from families are things like, well, am I going to get kicked out of the room when they turn 18 from the healthcare appointment? What if they refuse a procedure or intervention? Like we had a lot of people that did not want to take the vaccine because they didn't want the needle necessarily. A lot of families are told that they might need guardianship or power of attorney, or a lot of legal phrases get thrown out at this point, some of which aren't even necessarily a part of our legal structures in Ontario. They're just words that they're hearing out in the zeitgeist, so to speak, of what this means. Who gets to control the ODSP funding? What if they're not able to manage their own money? All of those kinds of questions. So I don't know if that resonates with you. I would like to sort of see in the chat if there's things that people hear or topics that they find that families bring up often. I'm just going to see if there's anything in there. Message consent is huge. Yeah. Yeah. So it's often around transition that these questions arise. I don't know.
Sarah brought up the home community care and support services family managed home care program.
Oh, yes. Yes. So originally that program required families to get guardianship, and it now no longer requires that because of some of these issues that we're going to be discussing in a minute that have been so challenging for families. So within the healthcare context in particular, I've packed a lot into this slide. So Ontario has very specific legislation, Ontario Healthcare Consent Act, that really outlines quite clearly if then kind of protocols as to what happens within a healthcare context around capacity and consent. So in terms of who can be a substitute decision maker, who can step up and sign a consent form if it's felt that the patient doesn't understand a treatment decision, is very clearly laid out. I made there's a little diagram on the right-hand side of that slide that shows the hierarchy of substitute decision makers within the Healthcare Consent Act. And so as a healthcare provider, if a person doesn't understand the nature of the treatment decision or the consequences, then essentially you're looking at from the top and going down, and you pick the highest ranked person that's available and willing to act as the SDM. Typically, very few people have someone that's legally appointed or court appointed. It's often a spouse or a parent or a child of the patient. So it's very clearly defined. If no one is available, then it goes to the Ontario Public Guardian and Trustee as a substitute decision maker of last resort. There were a couple key points that I wanted to highlight within here. So in terms of capacity, it's sort of the healthcare provider is looking at individual treatment decisions. They're not treating capacity globally and saying, oh, the person can't understand this decision. It means they can't understand this other decision. They look at it on a case-by-case basis and at a particular time. So maybe they aren't capable of making a decision 1 year about, their diabetes care, but maybe over the course of 3 or 4 years of learning more and gaining more self-management skills, they actually become more capable of making those decisions themselves. So it's not a static thing. And it's about whether or not the person understands the nature of the treatment decision and understands the foreseeable consequences of making that decision. And that question of whether or not, oh, am I going to get kicked out of the room? Am I allowed to be there? The patient gets to decide who is in the room with them. And so there's no sort of situation in which they're going to get kicked out unless the young person does not want that person in the room with them. They get the right to decide in terms of privacy. And then the limits on that right are if there's a scenario in which the person doesn't understand a treatment decision, then that's where the provider has to move towards this more structured hierarchy approach of who they can share information with, and talk to the patient about how substitute decision making works. In terms of our role as developmental sector workers, we're often placed in positions where we're really helping to be the glue in terms of communication of information between all of the different parties. And I think it can be sometimes a very challenging position to be in, but a very rewarding position to be in terms of making sure that everyone has all the right information at some of these appointments. So as a result, too, paid supporters cannot be substitute decision makers, but we often are playing an integral role in making sure information is being shared and discussed and values are being talked about. Angie, do you have anything that you want to add to that piece?
Not really. I think that, yeah, when we get into more about, I can comment on healthcare communication after, because I see that Jennifer DeCosta, she had a comment in the chat talking about healthcare providers being uncomfortable with proceeding with certain tests or procedures. I saw it, Jennifer, and I'll comment as well after.
Yeah. So I was a part of a group of authors for a tool that really we made thinking about larger decisions in healthcare in mind, where it was designed to sort of help providers with the idea of understanding more about their patients' support needs, understanding more about the nature of their intellectual disability, and how to adapt information so that healthcare information is accessible to them, how to accommodate their needs in terms of some of the things that might be helpful, because a lot of the time, refusal for treatment relates to being really frightened of pain or really frightened of a sensory experience more so than it relates to not necessarily wanting the treatment itself, and how to approach some of these things. And then last but not least, how and when to involve supports and people into the conversation and into the healthcare environment. So that is available on our DDPCP website. But it's again, like, it's all common sense. When I saw the names joining this morning, all of us are very familiar with these approaches, but it's a good reminder to yourself when a situation is overwhelming to take a look at some of these tools and think, oh yeah, there's a structure to this. There's an approach I can take to make sure that I'm really promoting this person's ability to understand information and empowering them to make these decisions. And then the next area is sort of financial decision making, which is much thornier and less clear cut than sort of the Healthcare Consent Act. And I would say when I'm working with families, there's sort of three areas where families have a lot of questions. One would be setting up a bank account, then the ODSP account, and the passport funding. And all of these sort of lead to this like last area on the bottom of guardianship and power of attorney and questions as to whether or not this is required. So uh, the issue comes up. I'll give the bank account as sort of the main example here. So with a bank account, you go into the bank, you have your ID, they show you what the contract is as to how a bank account works and what the responsibilities are of the bank and what the responsibilities are of the account holder. And then you sign a bunch of paperwork and voila, you have a bank account. But with signing that paperwork, it implies that you understand what you're signing, that you fully are taking responsibility for your end of that contract. And so with bank employees, if they suspect that a person does not understand the contract, it is up to them to decide that they do not want to enter into that contract. So you do get this scenario in which families where they're supporting someone with a diagnosis of a profound intellectual disability get stuck where they want to set up things in someone's name, but struggle to find a bank that will allow them to open something in that person's name because it is obvious to the provider that they think the young person does not understand the information well enough to set up the account. So they're then told by the bank, oh, it's okay, you can set something up in their name if you have proof of guardianship, or you can show us a power of attorney document. And then families will come to us as providers and say, I need a guardianship document, or I need power of attorney. And we are stuck in a position where we are not lawyers. But the information that kind of consistently comes out of this is that for a power of attorney document to be valid, you have the same issue arise. So in order for someone to assign someone to manage their finances for them, they have to understand the document with which they are signing. And so when you talk to Arch or you go into the legal aid clinics, if the young person can understand that they are what kind of authority they're giving to the person, their parent or their sibling, to manage their funds or their accounts, then that document is valid and you can sign the document and you have a power of attorney in place and off you go. But if the young person has a more profound intellectual disability, it's unlikely that they will let you sign this power of attorney document. And then you're stuck at this position of looking at whether or not guardianship is needed or not. When you consult with lawyers, like the pro bono lawyers at Sick Kids and at Holland Bloor Review and Arch, guardianship is a pretty extreme process. It does strip away a lot of the decision-making rights of that individual across the board. And it's a very expensive process for families to get, and involves like approaching Ontario Public Guardian and Trustee and a formal legal process. So what I tell families is that I have seen families have these three things in place: bank accounts set up, ODSP, and passport, without guardianship or power of attorney in place, but that I cannot recommend anything in particular from a legal framework, and I direct them to resources that I'll show you on the next slide, like Partners for Planning, that run regular sessions on this topic every 2 to 3 months. I see webinars put up with lawyers that are working kind of pro bono to put out these resources. They have a book that really outlines very clearly what the issues are and what the solutions might be. And then they also outline different legal aid supports that you can go to. So I often recommend that people go to pro bono clinics or legal aid clinics because there's not as much of a conflict of interest in terms of selling a particular service or a particular solution to this problem. It's more of a general consultation. So that's usually the approach that I take. Within ODSP and within Passport, there are forms and processes by which people can gain trusteeship or person managing funds. Those are the sort of two titles for managing the funds on behalf of a loved one. But in terms of whether or not this guardianship or power of attorney issue is going to become an issue, every family is different, every situation is unique. And so I tend to direct people to these resources and book appointments, and often go with them when they're chatting with lawyers around what their circumstances are. I also wanted to take a little bit of time to talk about an overall planning tool, because I feel like we're sort of digging into like little pieces of the pie all over the place. But this is a tool that I use to try and get a more holistic and comprehensive picture of this young person's life plan and goals and interests, as well as some of the like sort of key gaps that could be stumbling blocks that prevent some of the good things from happening. So the tool is called the Share Transition Plan. And we designed it with the idea that we wanted like an acronym that would help structure a conversation across a variety of different areas, so that we could identify key priorities for a person that's planning for transition to adulthood who has an intellectual disability. So the first area is supports for communication and capability. So that's looking at what how the intellectual disability is impacting on their ability to understand information, their ability to communicate back and forth, their ability to advocate for themselves, their experience with advocating for themselves and communicating with others, and sort of how they see themselves taking charge in the future. So that's kind of one general area. Then we look at healthcare transition and transfer. Are there major gaps? Do they have a family doctor? Do they have a dentist? What has their healthcare experience been like up until this point? What are their hopes and fears around that? And just making sure that we've identified what the key gaps. There's almost always a gap on that situation that we're trying to address, whether it's a psychiatrist or even dentistry can be tricky at times. And then activities and engagement. What does this person love to do? We purposely kept this neutral to sort of like employment and productivity, and kept it more about like, what is this person passionate about? What do they want to be doing? And for sure, I have a lot of people that are passionate about employment, but I have a lot of people that are passionate about, you know, I have one that's in one client now that's doing like musical theater, and he loves it. And that's the most important thing to him, right? um, Relationships and well-being. So we ask about friendships, we ask about intimacy and sexual health, asking about caregiver health, who is supporting this person, who's supporting the caregiver, and just really identifying if there's risk of crisis within there, or there's things that people are really wanting. And we put in well-being because often when you ask about mental health in sort of a looser way, like, do you feel like you're lonely, or do you feel like you're bored, rather than using like sort of clinical terms like anxiety and depression. You can kind of pull out some of the things that might be risk factors for mental health, and sort of talk about ways that you could have things that promote mental health as part of your planning. And then last but not least, by the time we finish that, we have sort of a picture of who this person's living with, what they like to do, some of their capabilities, and we have a sense of the supports they have in place for healthcare. And then I start looking at locally what is available in terms of services and supports, and how much does this young person and family understand about what is available. So with some people have not heard of DSO. It still blows my mind, but I often come across people in their 20s that aren't with DSO. When I worked at a family health team, like in downtown Toronto, like for the past 5, 6 years, I was on a project, and I still get family doctors contacting me where the person is not registered for a variety of reasons. Ontario Disability Support Program, really understanding how much money that is per month and what that looks like. I think many people are shocked. I had one client last month that really thought it would be $10,000 a month. She could not believe that it would be under 1,000, right? So giving people a bit of psychoeducation about what these services look like, what the amounts of money look like, and then also really giving a sense of what local programs are out there, wait lists, resources, just getting a sense of what the landscape looks like in terms of supports. This is just sort of a little sampler of what maybe those assessment questions might look like on the tool, just to zoom in a little bit. And then what that might pull out from a meeting. So you're basically putting out these feelers in these 5 different areas. And then as you're having a conversation, things will sort of emerge that are key priorities for everybody. So you might be chatting with a whole family and at some point realize like, oh, this caregiver has a serious health issue. So crisis planning is probably going to be a key priority for this family that wouldn't be for another family. So I find that I keep it pretty open-ended and I'm covering a little bit of a broad base. And depending, if you are working in a busy clinic, you might pick 1 or 2 questions for each of the categories. If you're working with a lot more time, like across time, like if you're a teacher or working in a scenario in which I don't know many people who have this time, but if you do have that prolonged relationship with the young person, you might delve into like 1 section at a time over the course of a year or 2. But they're all things that you can revisit across time and then pull out the priorities. I almost always, well, always start with an open-ended conversation where I ask about their overall vision for the future. I try to keep it neutral, and some families immediately gravitate towards the positive of what they are really hopeful about for this person to be doing. Oh, they really love dance and they're going to be doing this, and I hope that we can find a dance troupe, and I'm really hoping we can find things that make new friends, and they kind of move in that direction. And other people often will gravitate towards their worst fears. If something happens to me, what's going to happen to this young person? What's the housing situation like? All of the things that we saw on that Mentimeter pop out right away. And usually those are things that the parents are mentioning. And the young person oftentimes will be concerned with making friends, with leaving school, with employment, because they really feel that they're comparing themselves to same age peers, going to school, going to college, those types of things. So I try to, at the end of whatever conversation I had, reiterate all of the things they said at the beginning that they're passionate about, that are important to them, and make sure that the priorities that pull from this assessment truly reflect the priorities of the young person first and foremost, that we're really addressing that, as well as some of the practical things that mitigate risks. So I find making goals a really fascinating process, because it is really about trying to build consensus between different parties and really trying to understand and have empathy with what different people's fears and goals are. There's a lot of stakeholders that are being considered within this. Typically, though, it does help you identify priorities because you do have limited time. So it's a helpful way of, again, structuring this transition planning process. It's often easy to identify the gaps, and then it is really challenging to identify how to fill those gaps. So when I was asked to do this project, originally the PowerPoint I created was just jammed with resources. And then I realized, oh, this is Ontario-wide and may or may not reflect the Toronto resources. So I am a big fan of spreadsheets, and I have 8 million spreadsheets of different resources in Toronto, and I'm updating all the time. But each region is going to be very, very unique as to what's available and not available. And across time, we know programs open, programs close, wait lists, suddenly appear when something becomes popular. So the way that I've learned the most is by going on tours and meeting with intake workers and really developing relationships with service providers to get a full understanding of what constraints they're under, what they're doing within that sector, whether it's an employment thing, whether it's the day programs, just getting a sense of what these services offer and what they're facing within their own professional experience. Similar to what Angie was saying in healthcare, the empathy goes a really long way. And then in terms of peers, I am always phoning people. I was so excited to see the list of people and participants because I have no shame in saying, I'm looking for X. I just can't find it. I don't know if it exists or doesn't exist in this area. Can you tell me what you think might be out there? And then I am a big fan of a resource list. I'm a sucker for the resource list. I know they become outdated, but it's really helpful because you can share them with families. And when they are no longer able to access you as a provider, they have these hubs that they can learn to go to and turn to for their own support as well. So my community hub, respiteservices.com. Toronto Community Resource List is outstanding, and it has printable PDFs that you can hand to families of individual specific resources. So Tammy, thank you so much. It's been really fun kind of going through that. And then, yeah, I've been using that with a couple of families in the last couple of weeks since you shared that link with me. Again, the toolkits and guides, like I said, I highlighted that CCKO transition youth checklist earlier because it's very comprehensive. So it has things like a protocol for how to look for a family doctor. So starting with those CHCs, community health centers, moving to the family health teams, then going to different things like healthcare, what is it called again, Angie? My brain is Healthcare Connect. There we go. I wanted to say Connect My Healthcare. I don't know. There's also a website called iamsick.com. So it's like all of the structure of like, what do I do? I have this problem, and it's a common problem we all have. There's guides, toolkits, resources out there that can help you systematically go through and try to fill these gaps in resourcing. Like Angie said, it's persistence that really wins the day with all of this. We can't really change the fact that there's a primary care shortage. We can't really change the fact that there's wait lists for day programs. So it really is getting a good sense of what's out there and then being persistent and being very empathetic with the providers that you're interacting with around the constraints they're facing within their own sectors. I did include sort of resources by category. I calmed myself down and then put it in terms of resources that are available that would be helpful across the province. So within healthcare, we have the link up there for HCARD, the Developmental Disability Primary Care Program. For activities, we've got respiteservices.com, Connectability, the Toronto Community Resource List. I still threw it in there because it's pretty comprehensive. Even if you're outside of Toronto, there's things there that are really useful. Sexual health and education. I tried to highlight a few of my favorites or key ones. But again, I'm very self-conscious that Deanna's in the room. So I just picked a couple. and financial and legal sort of put this all on one page as to sort of the key resources by category that you would be turning to when you're searching to fill those gaps. So we left on purpose a bit of time for discussion, and we kind of wanted to open the floor to the rest of the group. We have our references as well around what you're facing or what you're seeing in your practice for this age group.
And I kind of wanted to circle back to Jennifer's comment because I think it was a very important one. If you see earlier on, Jennifer had commented that sometimes healthcare providers are uncomfortable doing certain tests or procedures due to the fact that people don't communicate using words or traditional ways. And that's quite key in terms of barriers, especially with transitioning someone who is young, a young adult, and may not be known to the new providers. And I think it's looking at, okay, why? And it's always a balance of risk versus benefit. So it's looking at communicating again with the provider. Why are there certain risks that are outweighing the benefits? Is one of the risks medical trauma? Because often it's a major reason why a healthcare provider wouldn't proceed with offering a test or a procedure. And how can we then support that provider in terms of seeing where there might be ways to help medically traumatize less? And we're coming with the developmental disability specialty lens. So we go in there confidently saying, knowledge of the person and not being their voice, but their microphone. And in order to be the microphone, you need the evidence from the person directly. What was history in terms of them tolerating certain things? What was their history? What are ways to support their communication with us being the developmental disability specialists? And is it that our role in the room might be the communication translator using evidence from their nonverbal communication? And we're already doing it. We're doing it very well. The only difference is sometimes we need to tell the story with the healthcare language. And when we're in the room and they say, so they present a theory, we have about 22 seconds to come up with a response and be very concise about it. So again, the structure, preparing ahead for that medical visit. If we are faced with things that are unexpected, like the provider says, I wish I could do this, but I don't see how we can do it. It's saying, okay, let me take it back to the team, or let me discuss this with the person and their family in their way of communicating. And then on the spot, make a follow-up appointment so that you have that structure and a deadline as to when you can come back and respond. There's also a new OHIP billing code that helps with the length of time it might take a provider. You're seeing in the media that they're talking about how many hours they're spending in extra time that's not billable, that they're not getting paid for. So this new OHIP billing code is linked to physical health check for people with, specifically, people with developmental disabilities. K133 pays a little bit more money. And when you see how much it is, you might think, oh, really? I was a little shocked. It's not that much, but it's a little bit more incentive to spend more time doing the assessments and the procedure related to health checks, for example. I don't know if that helps, Jennifer. I had so many thoughts when I saw your comment. So thanks for commenting.